everybody. So they said the first slide should be biography, and I don't see anything great to talk about with myself, but internet can tell you about me. That's PubMed. That number is now changed a little bit. Google Scholar could tell you about me. Nothing great, just, academic doctor publishing. Instagram could tell you about what we do. That's biography. Pelvis exam. We can't talk about the pelvis as though it's an isolated entity. It's connected to the entire body, and that's what you're going to see. We can't talk about the exam without talking about treatment, so you're going to see some of that too. So when you go to your exam, on exam day, you're not going to see this as a clinical case. There's probably only 2 physiatrists doing pelvic floor, me and Navita Vyas, right? But in the theory, it could come in. And when it comes, it's going to come to you as Kegel exercises, pelvic floor rehabilitation, chronic pelvic pain, pelvic nerve blocks. As an examiner, if I put this question for someone, I would look for these keywords to make sure they've written the right stuff. Puborectalis, pelvic sling, Kegel, hypertonic, Laycock, Oxford, therapeutic exercise, nerve block, mindfulness. So when you hear this talk, listen for those words, see how they fit in, so you can absorb the points. The objectives here would be to talk about the etiology of pelvic floor dysfunction, the examination, of course, and then treatment options. And the examination will be stressed quite a bit. 2 to 16% of men will have pelvic floor dysfunction. 1 in 3 women will have pelvic floor dysfunction. 90% of women with back pain will have pelvic floor dysfunction. It's not that uncommon, just most people don't know to look for it, or they kind of ignore it. The other side of this is something different. Pelvic dysfunction not otherwise specified. So sexual dysfunctions, 43% of dysfunctions in women and 30% of men have sexual dysfunctions. Almost always they'll have some pelvic floor dysfunction. Hypoactive sexual desire, 30% women, 15% of men. Again, there can be pelvic floor dysfunction within these people. 16% of people with constipation within the past year, they will likely have pelvic floor dysfunction. Urine flow problems, when it's not otherwise found out to have a specific nameable, treatable etiology, will have a pelvic floor dysfunction. This is what we often miss. So when you get these cases, your job is to find out the root cause. And there's going to be 2 different issues that we're really looking at here. One is an unnamed diagnosis or a functional diagnosis like Venusar was talking about yesterday, or a known diagnosis with a poor response. So we know that it's this, we did the treatment, they're not magically better, what's wrong? The common denominator here is always going to be the musculoskeletal system. And this is what's been missed because our colleagues don't understand it. And the other thing is, your mind won't know what your eyes can't see. So if you don't look for depression, you don't look for myofascial pain syndrome, post-surgical adhesions, endometriosis, irritable bowel syndrome, inflammatory bowel syndrome, biomechanics, infections, cancer, and trauma, you will still miss what's going on because primary pelvic floor dysfunction is really rare, but it's often related to these kinds of things. Myofascial pain, we treat it every day, right? Who looks for pelvic floor dysfunction? Anatomy is everything, especially in PMR, right? I keep this on my desk. I show it to my patients. This is the pelvic floor. These are the muscles that form it. It's not one muscle. It's 26 different muscles. But if you show them this, they can start to understand that even though it's a muscle dysfunction, you have a urethra running through it, you have a rectum running through it, you have blood supply to gonads running through it, and if those don't work, the other things won't work. Whenever we examine, we need to have a quantifiable, standardizable exam. Laycock is one exam, and the Oxford is the other type of exam. I use Laycock all the time. It's quite good. It gives you a good amount of detail. That's that one perfect R at the bottom. What is the exam? What is the exam of the pelvis? It's essentially going to be muscle testing, Medical Research Council, scaring. You have a clock position. You can see that here. And you're going to look for all the different muscles. The clock positions correlate to particular muscles. You'll look for trigger points within those muscles. You'll look for neurological control, patterns of presentation, interference. And this is what the Laycock exam actually tells you. This is how people respond. You want to do that to me? No way. The urologist did. Why do you want to do it? Right? But in fact, what we're doing is a quite unique exam. Urologists won't look at particular muscles. So this is a hard thing to overcome. Some people refuse at this point. We do nothing more with them. When you're ready to come back, we can examine you. Otherwise, goodbye. But this is the first step. What we're aiming for is to get to a treatable diagnosis. And this is a hard thing. You see, everyone has already seen, they've had their say, their investigations have said yes or no, but the person still has a dysfunction, that's why they've come to you, right? So is it a myogenic problem, where you have an agonist-antagonist imbalance? Is it a problem of cortical representation? Is it a myofascial trigger point issue? Is it neurogenic, from peripheral sensitization or viscerosomatic overlap? Is it psychogenic? That's what we're going to try to figure out here. And that's what the exam is all about. Step one. You can't look at the pelvis without looking at the entire body. You have to consider posture, right? So all these different posture types, if you look at it, kyphotic lordotic, the second one, has an excessive anterior tilt in the pelvis, right? Here's a flat back, and the flat back has a retronutation. It's gone backward. A sway back has retronutation, but a shift forward also. And that, of course, will affect all the muscles in the pelvic floor because they originate from within it. Oh, sorry. So these postural deformations will affect muscle function. A muscle is designed to function within optimal length. If you make it too short or too long, it's not going to work properly. If it doesn't work properly, you have dysfunction. Next is testing the pelvic muscles, right? So when we do this, our approach is to see, is this a flaccid pelvic floor or is it a hypertonic pelvic floor? A flaccid floor easily accommodates your finger, maybe two, right? A hypertonic pelvic floor is very tight. You have to really push, twist, and screw your finger to get into that thing. They're screaming and it hurts, right? But the reason to this is because pelvic floor rehab is not just Kegel exercise. That's what everybody knows. That's all they know, in fact, right? If you Kegel on a hypertonic pelvic floor, you'll get more pain. Our colleagues don't know this, right? You can do it for a flaccid pelvic floor. There's much better ways to fix it than Kegel, but yeah, that's where Kegel is appropriate. So then if it's hypertonic, why? Is it an upper motor neuron condition? Is it non-organic? Is it structural? Is it functional? Why is that sphincter so tight? And then which muscle is in dysfunction? Or which groups of muscles are in dysfunction? And were there myofascial trigger points when you inserted your finger in the rectum and palpated around in those different clock positions? So this is the first little grid we come to. Is it a painful or a painless pelvic floor? Is it hypotonic or hypertonic? You're going to tick one of these boxes. And this is the first set of information you have after your structural exam. The next is the structure of the pelvis, of the actual architecture of it, right? So the way the pelvis sits, it's actually a ring, but it's a ring with three parts. So you could have a nutation in the pelvis. I'm going to try to show this to you. Bear with me. If you saw that, one part of the hemipelvis moved forward, and conformationally, the other side will move back, right? And so as that happens, the muscles that originate from within will start to get torn or shortened or lengthened, right? So you can have anteronutation, retronutation, you can have a shear, you can have a torsion, where the entire pelvis, not sitting straight, but tilts like this and follows the ilium that's nutated along with it. This is what we're looking for, because these are all external cues telling you what's going on in the pelvic floor and which muscle should be in dysfunction. Pescatore. Pescatore is this urologist from Italy, and he came out with this, I think maybe OBG, sorry. He came up with this whole iceberg theory. And his thing was to explain why women in their 50s and above will have stress incontinence. So Pescatore said, they can have all these symptoms like a constipation or residual urine problem. They can have their incontinence, etc. And he attributed it to the different slings of the pelvis. This has been extrapolated into chronic pelvic pain. an apical prolapse. So this is from a publication on the same thing. And we can see people who now have pelvic floor dysfunction will have residual urine, nocturia, stress incontinence, frequency, bladder emptying, urge incontinence, and along with that, they'll have pain as the most obvious thing. But if you don't identify these, you won't be able to treat that properly. So a good history and a good exam reveals all of that for you. This is Pescatori's little model, and Pescatori came out to say there's 3 slings in the pelvic floor. So the front ligaments, the anterior sling, the intermediate sling, middle ligaments, and the back ligaments, right? So if a person has a dysfunction in their front ligaments, you're going to see a lot of stress incontinence, fecal incontinence, right? If it's in middle ligaments, you're going to have abnormal emptying, frequency, and urgency. If it's a posterior sling issue, it's going to be rectocele, apical prolapse, abnormal emptying, frequency and emptying, obstructed defecation, pelvic pain. What you're seeing here is all the conditions our colleagues hate treating because there's no great way for them to treat it. But if you can identify this through your exam, you won't be able to treat them either. So the next part is the autonomic nervous system. And this is really complicated, so I'm sorry, but I have to show you a basic neuroanalogical pathway. So you have a control center, you have an efferent limb, you have an effector and an afferent. Right? Now, when we apply this to autonomic nervous system, it's throughout the entire body, all the way into the extracellular matrix from the brain out. What you see as a control center is the integrated set point center, which is the rostrolateral ventral medulla, nucleus ambiguus, and the nucleus of the solitary tract. Right? Now, this is the control center that says, hey, fire, 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 right? And when it fires, what it does is it activates the autonomic nervous system, the sympathetic, parasympathetic tract, that's your afferent pathway. And this works on the immune cells, which then release cytokines. The cytokines are detected by the afferent, and that's going to tell the control center the job is done. Now, this particular pathway is from immunology, and it's for inflammation, and the model they use to explain autoimmune conditions. So this is a closed network. It's quite well controlled. If I was to bump something, I would get a swelling here. It would go away with time too, right? It's a stress response to heal the damage, right? The problem is this can be independently activated. So you have endogenous ligands, like HMGB1, which is nuclear degeneration material, heat shock proteins. You see someone you don't like, you have a negative response mentally, heat shock proteins are put into circulation. No trauma has happened, you saw something that you didn't like, you now have inflammation. Proteins, uric acid, interleukin-1 alpha, nucleolin, or even exogenous ligands like lipopolysaccharides, lipoteichoic acid. These are all bacterial products when they're destroyed in circulation, right? So leaky guts allow for really unharmful bacteria to get into the circulation. They're destroyed. These produce inflammation. And what triggers all of those things are response to environmental stimuli. I see someone I don't like. This triggers endogenous ligands. Memory stored in the amygdala. I see someone looking funny. It triggers a memory I have from years ago. Inflammation. Bad posture. You have lactic acidosis, trigger point formation, inflammation, right? Pro-inflammatory food with a lot of preservatives inside of it, or sugar, or unrefined carbohydrates, right? Refined carbohydrates, sorry. Myofascial trigger points, age proteins. Our diabetics have all these advanced glycation end products, right? They independently attach to the muscles, they induce inflammation, they perpetrate inflammation. All of these directly lead to ligand formation that independently activates this inflammation network that leads to autonomic nervous system overactivity. And this is where things get messy. So you have this immune set point center, you have your afferent, efferent, you have your immune cells that release their cytokines. When this happens enough, you start to find people who started off having a bladder symptom, now they have constipation, now they have genital pain, then they get a back pain, right? It becomes a vicious cycle. And why? All those sensory feedbacks feed into the dorsal root ganglion that correlate for other functions too. So one function takes over, things get blocked, they don't work, and now you have dysfunction in general. What it all boils down to. If you've never heard of Janda, he's one of our physiatrists from years ago. This is from his book. This is the boss and the worker, right? So you could have a really irritable boss who's angry all the time, nothing's good enough, and the worker is always stressed. Or you could have the absent boss who's out partying and doesn't do any work, and the lazy worker, because no one's there to tell them what to do, right? So when we look at the pelvic floor and the entire body, we can see that there's going to be contractile elements here, or the neuroreflexive components, and then the viscoelastic and adaptive components, or the muscle. So if you have an angry boss, it could be limbic system overactivation, it could be myofascial trigger points activating the limbic system, it could be a muscle spasm. That is why you have the angry boss, or the overactive brain, the anxious person, right? And what happens to the muscles? They start shortening. They're afraid to do anything, so they're always tight, ready to go, right? The other side is the absent boss, the guy who's out partying all the time, never comes to work, whatever, right? It's even more messy. Reciprocal inhibition through the Renshaw cells in the spinal cord, right? Arthrogenic weakness, deafferentation, pseudo-weakness, trigger point weakness, fatigue. And the lazy employee, or the muscle, what happens to the muscle? It'll become overstretched and weak, or it'll become tight and weak. So this is what it all boils down to. All this exam is designed to get us to this point. You have to consider associated symptoms, so rank them by severity, so you can see how they go. Constipation, tenesmus, urinary urgency, frequency, incomplete voiding. They can't receive a penetration, they can't give a penetration, they can't maintain an erection, they have pain with penetration, all these things come up. And then we do a root cause analysis. And this is really messy. So I'm going to take your attention to just these areas, right? If you have a myogenic issue, where it's purely myogenic and nothing else, rare, but if you get them early enough, it could be that. Posture could be normal, it could be abnormal. Muscle exams on the pelvic floor could be normal or abnormal. The structure of the pelvis could be normal or abnormal. But the ANS should not be involving, it should just be one system. Just a genital pain, just a urinary symptom, just a constipation, nothing else. The next thing is neurogenic. Now, neurogenic is slightly different in that these will be abnormal, but this may or may not be, and it's kind of hard to sort this out. And the last is psychogenic, where you'll definitely have autonomic nervous system involvement. There's a good degree of overlap between these conditions, so it's really hard to sort things out, but mentally you want to have this kind of approach so you can figure out what's treating, what to move to next for treatment. Okay, yeah, outcome measures. We always need to have outcome measures, and those will tell us how things are changing for the patient. Of course, they'll tell you, I feel better, I feel worse, but it doesn't always correlate to the response to treatment. So a visual analog scale pain, myofascial trigger point count, symptoms that I mentioned before, the exam findings of these past 6 steps, non-organic or their affect, their activities of daily living, their quality of life. Those are the things we look at, and you keep tracking these on follow-up. Electrophysiology is useful. There is pelvic floor EMG, and we can see that if a person sits in a slump, there's going to be even more increased activity in their pelvic floor. It has to stabilize all the rest of the body if they're not using support, right? Women with incontinence will have excessive pelvic floor and abdominal muscle activity with postural perturbations. Diagnostic ultrasound can show you trigger points. That's probably a trapezius picture, but you can see trigger points. It's a rectus. But you can see trigger points when you look, and you can inject those. Treatment. So this is in a nutshell. I'm not going to spend much time here, but rehab is essentially going to be exercise programs, lifestyle modification, and interventions. The exercise programs would be pelvic floor exercise. You identify the muscle that has a problem, you treat that. You identify the pelvic architecture dysfunction, you treat that. You treat the entire posture, right? Breathing correction. The pelvic floor is a diaphragm. It moves with the actual diaphragm. When the diaphragm moves up, this moves up too. It moves down with it until it's in dysfunction, So you can train a person to breathe properly and get their pelvic floor to work and relax properly. And then EMG biofeedback. You put a probe into the rectum and you train to contract and relax the muscles. Lifestyle modifications is grossly underrated. It's very important. They should not be entertaining negative thoughts. They should learn to control that stuff. They shouldn't be overstimulating themselves. They should be losing weight if they're overweight. Activity modification, if they're sedentary, they should be more active. And then interventions, what everybody else likes to hear about. So the nutrition is the big thing. This is essentially the My Plate thing, which is an ADA diet. More and more vegetables, more and more fiber and fruits, less grains, less proteins. Yeah? Common sense. Oh, sorry. I wanted to show you something. Look at this. You can see this full body colorized MRI of a normal person. Am I out of time? Okay. You can see this chunk of fat sitting in this person's belly pushing the bladder down. They're the same height, right? But this chunk of fat is pushing their pelvic floor down, the bladder down. The pelvic floor spasms to hold that bladder in place, right? This is why they have such dysfunction. Those muscles are working twice to thrice as hard, holding weight they're not designed to hold. So weight loss is critical. Ergonomics. So our teachers keep telling us sit up straight, sit properly, maintain your lordosis, don't sit in a slouch. But changes in pelvic floor laxity are increased in the sitting position. And unsupported sitting postures, if you're not using the backrest, can put a lot more strain on your pelvic floor than supported sitting postures using the backrest of the seat you're using. Yes. Breathing. So the diaphragm and the pelvic floor move together when a person breathes. The simplest thing is you tell them to put their hands on their head, make sure they expand their chest, make sure they pull in their belly as they're doing this. They can fix their breathing, and they'll actually start feeling better with this. I often tell them, push out the breath through your rectum. It's physiologically impossible, but they'll get the idea and they can relax their pelvic floor that way. Interventions. When do we do interventions? If their visual analog scale pain is less than 5, we're going to talk about the rehab program, the lifestyle modifications and that kind of stuff. Right? If it's more than 5, it's warranted to talk about injections. They won't agree. Nobody wants needles down there, but it's something to consider. So if they have no myofascial trigger points, predominantly neuropathic pain along a particular nerve's distribution, a trial of a nerve block makes sense. If you have no change in the visual analog scale, reassess. If they are better, if the visual analog scale pain has come down, lifestyle modifications. Back to basics, right? Breathing, weight loss, mindfulness, etc. If they have myofascial trigger points on exam, with or without vague neuropathic pain, so they'll say, my right testicle hurts, my right labia hurts, right? And there's nothing that particularly triggers it, right? This could be trigger points causing it, especially if you find them. They don't have to be obvious on every exam, but they can be there, right? So you would think about prolotherapy or trigger point injections depending on your preference. I use Prolo. Reassess. And with reassessment, if you find that there are still trigger points, it's okay. That actually happens. If you knock out a few trigger points, a new crop will pull up. The old ones can start to emerge. It's not a problem. Prolo again. The standard prolotherapy course is 4 injections over 8 weeks. You can keep doing this until they get better. It's not a problem. If there's no more myofascial trigger points, back to basics again. The rehab program, right? Breathing, weight loss, posture, all that, right? There's another kind of patient that all the other doctors hate to deal with. They're going to be called psychogenic. They might have psychogenic symptoms with visceral dysfunction, so psychogenic visceropathy or viscerosomatic overlap, right? This is where I use neural therapy. We're done.
Sir, we get lot of females in our OPD complaining of back pain. And upon getting the history, they are like, they have long history of white paravaginal discharge. May it consist of PID. Sir, what is your opinion of any low back pain or pelvic pain in PID? Which is more? Which we have to concentrate more? In pelvic inflammatory diseases, is
Mm-hmm.
it more of pelvic pain or low back pain?
That's a trick question. I haven't done enough to give you a straight answer. I think here's the thing, right? Eventually, all those sensations will feed into the same dorsal root ganglion. So, for us to understand something, we label it, and we have these criteria that make a label for us. But it doesn't mean that they won't dysfunction still, and that doesn't mean they can't be the same symptom. So, from a neurotherapy approach, looking at the dorsal root ganglion all the way back out, they're probably the exact same thing. If you block the autonomic nervous system and reset it, it should fix. But I haven't dealt with enough of that. I think I have one lady right now who has pelvic floor dysfunction, PID, and then migraines. And she only told about PID just recently. She's been having migraines for years, right? So when I start treating that, I can probably give you a better answer.